Corneil, it's Kim here. There have been a couple of questions submitted in the chat box, and Christine, if you're able to unmute Michael, that would be fine, but in the interim I'll just read off a question that Michael had. Michael asked Dr. Corneil, why did you separate out methadone from the review?
It's a good question. We the
Dr. Corneil, we've lost your connection again. Dr. Corneil?
as an opiate replacement.
Dr. Corneil?
Dependence.
Dr. Corneil, we
Yeah.
lost your connection again. Can you answer the question from the beginning again, please? Thank you.
Sure. You can hear me now?
Yes, we can hear you now.
Okay. Okay, good. So the number of methadone, accidental methadone overdoses was actually very low. And so having such a small number makes it very difficult to draw any conclusions without the full access to the drug database. We do actually plan on doing a sub-analysis when we're provided with access to more information. But it is certainly something that people talk about.
Great, thanks, Dr. Corneil. Second question from Michael, actually. What's the reaction been from regulatory professional bodies and other doctors, pharmacists, etc.? Are you seeing any changes in practice based on your findings?
Very interesting question. It's difficult to measure change in practice. The physicians that we have been in touch with and some of the divisions of family practice all noted that they were surprised, and their biggest surprise, well, there were two. One was that it could happen at a low dose, and the other was that, in fact, multi-doctoring was not the issue. So we've gotten at least some qualitative feedback from the physicians. The College of Physicians and Surgeons and the College of Pharmacists have both been incredibly supportive and have begun to include this information into their education to physicians and pharmacists about some of the risks related to opiates. Although they're not able to pull aggregate data in the same way that we can for people who are, in this case, deceased, they can pull out individual physicians who are high prescribers of opiates and go over some of the cases with them. And they have now started to point out the use of multiple medications. Have we seen a decrease in the rate? It's too early to tell at this point. That certainly was 5 years worth of data. I think if we are able to convince all the health authorities to engage in this analysis at a provincial level, we may be in a position to do some proper monitoring going forward.
Hi, Doug. I understand you have a couple questions.
There's been a question from Doug Spitzig, and that's great.
Doug, go ahead.
Hello?
Hi.
Yes, I was wondering with regards to the toxicology.
Hi, Doug. Go ahead with your question.
Okay, I was wondering with regards to the toxicology with the anticonvulsants, whether gabapentin was prevalent.
Yeah, gabapentin was certainly, we probably saw that in about half of the cases, and the other half of the anticonvulsants were some of the newer ones which are being explored in chronic pain. So gabapentin was a significant medication found in the toxicology.
Okay, thank you. Christine, are you able to open the mic to Mike, Ada and Anne? I think they have some questions as well.
I've opened the mic to Anne at the moment. Anne, go ahead and ask your questions.
I wrote them all out. I just have to find them. First of all, was it clear was there any suggestion that the individuals were taking more than the prescribed amount of opioid, or was it very clear from the toxicology that they were taking exactly what had been prescribed?
Toxicology results are actually quite fraught with problems. It really and we didn't know this until I actually started to ask about it. But where one draws the blood post-mortem and what and how one actually tests make the levels quite variable. So in each case, there was a pathologist who was able to understand toxicology and what the opiate levels were to say that it was in fact the opiate that was the primary cause. And sorry, what was the second part of the question?
There was no suggesting that they were taking more than that, and but I think you've answered that.
Oh, right. So yeah, so and that's what I was going to say. We were able to look at those 26 cases that had their prescriptions out of the database, and we were able to compare those to the notes. So when we looked at the coroner's notes, they would actually also usually write how many pills were left in the bottle and how many pills there were supposed to be. So people did seem to be taking the right doses.
Right. And were there any particular opioids that were through, information around it that were identified as being part of the problem, or was it fairly widespread among different kinds of opioids?
It was quite widespread. There was certainly a significant amount of oxycodone, as that's a favorite. People seem to use a lot of hydromorphone in BC as well. The concerning one, and this has been a concern of mine since my own clinical practice, is the use of fentanyl patches for chronic pain. And I'm excluding, of course, the palliative group from this, but we did see some really nasty cases that involve fentanyl patches.
Thank you.
I believe Ada has a couple questions.
A question from Poppy.
From Kathy. Go ahead, Kathy. You've been unmuted.
That's us, Kathy.
Kathy, are you there?
Hi.
Hi. Go ahead.
Hi. Go ahead. The question. What are some of the common adjuvant non-opioid meds that may be contributing to overdose deaths?
Are you able to repeat that question, Kim?
What are some of the common adjuvant non-opioid meds that might be contributing to overdose deaths?
What are some of the common adjuvants?
Yes.
So certainly the most obvious ones for those of us who are clinicians are the benzodiazepines. If you look at the screen, benzodiazepines are significant. There's no doubt that they have an effect. I'm really not convinced about the role of antidepressants, but when you talk to some of the clinical pharmacologists, they wonder, and they've been talking about it for some time, about the interaction between opiates and antidepressants. So I'm quite curious to see what we're able to determine in the next phase of our study. And then the anticonvulsants. So that from our perspective, the two major ones were the benzodiazepines and the anticonvulsants. That said, the toxicology shows that antidepressants were there in most of the cases, and there was significant use of antipsychotics, most of those the novel. So I think it'll be interesting to see
Okay, next we have a question from Ada. Christine, if you could unmute Ada, please.
Ada, go
Hi.
ahead.
I wanted to know whether this information was, yes, hi. I wanted to know whether this information was shared with other Canadian provinces and territories, with other coroners' offices, and also with something so serious, why aren't we informing patients before they're placed on these opioids? I heard Dr. Corneil, I heard you say that that you did provide information to the pharmacists or the, I guess, the College of Pharmacy in British Columbia, but to me that's a little too late. People should be aware of these problems before they even receive a prescription from their doctor. So I want to know, is this information being shared with other provinces, and what else can we do before putting patients on these drugs initially? Thank you.
Excellent question. We really had to think about how to approach this, because although the information was significant, it was only interior health. When one looks at the literature, again, it stops, because most states, most countries that are dealing with opiate issues, many of the provinces in Canada don't have a good drug database to pull from, and the coroner's notes are not as accessible. So it's early days in trying to clarify what the problem is. So our first approach was to do a direct to physicians and pharmacists to provide those who were on chronic pain. And we decided to do what we refer to as a soft media launch, which is wait until the media picks up on the story and then let it go from there. So about 2 weeks in, the media did pick up on the story, and I was on CBC, Almanac, and various news cycles. So there was about 24 hours, every half an hour, people could hear me give some soundbite or other about this. So we have used media, and of course, finding a way to share this information out. So we've done that through the most of the Canadian organizations involved at this point with overdoses. So each province has a committee that is looking at these, and they tend to, and then they meet. We're a bit hesitant to go to the chronic pain specialist yet, because I need something more specific, and the delay really has been, I call it, you know, being trapped in red tape. We're really just waiting for access to information so that we can get something more granular. So absolutely, I think as soon as we have enough to confidently provide some specifics, widespread communication and certainly publication would be a part of this.
Thank you, Dr. Corneil. It's Kim here. Before we get to Shauna, you had mentioned that there was a next phase of the study. So just taking off on your previous comment, are other is other research in the works, or are other colleagues doing similar research?
A lot of people are doing research with regards to prescribing habits around opiates and opiate overdose deaths. And so people have certainly confirmed that although the rates have decreased, they haven't dropped to zero, and there is something else going on. It is all about the capacity to access the drug database. And so we're reasonably reassured that we'll have access to that for this 110 cases soon. And that's where we'll start to try and line up different adjuvant drugs with different toxicology results and try and interpret those. We have had people in Ontario who've shown interest, in Alberta, other areas in the province, and from the States, and I think that there is a lot of potential. I do think it's going to require someone to make it very clear that something is going on, and I think we're going to be able to do that. And when we do, I think a lot of people will come on board because it's certainly seen as a real problem. So phase 2 will be being able to say more than we think. Well, we see a problem, we think we know what's happening. We want to be able to say, we know what's happening, and let's get everyone on board.
Okay, fascinating. Thank you. Shauna, let's unmute your line and take your question for.
Go ahead, Shauna. Okay, Shauna was asking sorry. She doesn't have volume. Okay. She was asking, is naloxone as effective with fentanyl users?
Well, naloxone is effective with any opiate. It will immediately reverse the respiratory suppression. The problem with naloxone is that it only lasts for about 30 minutes in your system. So you actually have to also add a 911 call or repeat doses, and that's part of the education of the take-home naloxone program. But a high enough dose of naloxone will strip all the opiate receptors.
Okay, thank you. There's another question from Michael Parkinson. Christine, are you able to unmute Michael so he can ask the question?
He is unmuted. I don't know what the problem is.
Oh, okay, I can go ahead and read the question if that's all right then. Michael writes, in the U.S., the CDC, AMA, APHA, etc., they describe the death addiction rate as epidemic and lots of action on the ground. Can we expect Health Canada and the feds to show an interest? And do you see a role for Health Canada and the Public Health Agency of Canada to get involved?
Yeah, absolutely, Michael. It's actually really interesting. We do in Canada see every year, it seems to be October, November, they run the Fifth Estate program on opiates and the role of the particular pharmaceutical company that produced brand name oxycodone and its introduction. This year, for the first time, CNN in one of their investigative documentaries, this one by Sanjay Gupta, showed he was starting to demonstrate this whole case of drug stacking. So people are looking into it in the States, but it was interesting. He wasn't able to find anything beyond what we were. And when we explored this further, it really had to do with an inability in the States to access helpful drug databases on people who were deceased. So we are in Canada fortunate to have some support, and Health Canada has expressed interest in engaging with us in exploring this. At what point they will engage on a countrywide or federal level is hard to say, but they're certainly supportive of what we're doing right now.
Oops.
Okay, last call for, thank you, Dr. Corneil. Any last calls for questions?
Sorry, Jane has one, and so does Anne. Anne says, you see the issue as important enough to supply naloxone kits locally to prevent deaths, yet want more information before approaching pain doctors. I wonder about the importance of the precautionary principle.
Can you repeat the first half of that question?
You see the issue as important enough to supply naloxone kits locally to prevent, I'm sorry, it went too fast, to prevent deaths, yet want more information before approaching pain doctors.
Again, it's a question of timing, and some of the reaction we've had from pain physicians. They have said, and these are people who do either a lot of practice or are involved in research, have said, we want to know more. So we certainly have engaged pain physicians and pain specialists and are working with them. And the question they ask is fair, which is what information or what evidence do you have, and which drugs should we avoid? And that's a question that I can't answer. So precautionary principle, of course, is, not to take the chance, but to take the next step and say, don't use adjuvant drugs is too big a step. What we've really asked physicians to do is to review their chart files and try and, for lack of a better word, clean up the prescriptions, so that we don't have people on 10 different neurotoxic drugs at a given time. But again, this is in progress. We've only had this information and have been able to begin communicating it as of October, and this webinar is a part of us getting the information out as widely as possible while we continue to work on some of the more specifics.
Okay.
Thank you, Dr. Corneil. This is just fantastic. Are there any last questions, Christine, before we wrap up?
Yes, Jane has a question. I'll try to unmute her. Jane, go ahead.
I just wanted to know, other than the Interior Health report that was sent out in October, have these findings been reported, in journal or somewhere else that we could sort of look up and refer to, like the CMAJ or anywhere like that, and where can we find them?
Yeah, not yet. It's still in the gray literature. Again, it's a question of timing. We had been waiting for the other data, thinking we'd get it in weeks. Every 2 weeks we think we're getting it. It's another 2 weeks. So we've already approached CMAJ, and it will probably come out in some journal somewhere soon. We're certainly at a point where we're ready to say, listen, we need to put this information out in the peer-reviewed context without some of the detail and explain our limitations as best we can. So that is certainly a next step. So you're hearing a lot of this. It's sort of hot off the press in public health are what we have to do is communicate what we find and try and affect change as quickly as we can. Publishing comes second, so it's one of those things that's on the side of the desk.
Okay, thank you. And for our last question, we'll bring on Sean. And
Kim, I think we lost you.
hi, can you hear me now?
Yes. Sean, go ahead.
Oh,
Sean doesn't have audio. Sean asked, we run a 20-bed medically supported detox unit and had a naloxone presentation to clients. It was very poorly received as clients saw this as negative, not believing in them. Please comment.
I think that's what is so interesting about the take-home naloxone program in BC. This is a newer pilot. In other words, it's based on evidence in some of the practices out of Ontario and the States. We are we're trying to engage people in a different way and bring them on board. And a big part of the assessment within this pilot is how can we best engage injection drug users or other people who are who might be resistant to it in a better way. So we don't know the answer to the question, but we are at this point, at least in terms of uptake of our naloxone kits, we are finding that there is interest. So maybe who is presenting it? We're using a lot of community agencies and nonprofits to deliver the information and to offer the kits, as well as local physicians where some trust has already been built. Hopefully we'll know more specifically are the ways or the best ways to approach people who would benefit from a naloxone kit and communicate that out when we have it.
all right. Thanks for your response to that. Well, our time is pretty much up, and I want to thank everybody for joining us today for the webinar, and a special thank you to Dr. Trevor Corneil. Thank you for taking the time today to share your initial results. It's just fascinating. And perhaps even more importantly, thank you for your pioneering work in this area. And it's tricky to do both the research and to get the knowledge dissemination out. So we hope by use of this webinar and posting it online and tweeting about it that many more will benefit from the information you've gleaned so far. So thank you so much.